Okay, we're going to talk about Chapter 20, Cardiac Glycosides and Heart Failure. Objectives are identify the major risk factors associated with the progression to heart failure, relate how the symptoms associated with heart failure may be caused by the weakened heart muscle, categorize heart failure drugs based on their classification and mechanism of action, identify representative drugs and explain the mechanism of drug action, primary action, contradictions, precautions, interactions, and important adverse effects. Okay, so looking at heart failure, remember when we talked about heart failure, it has, for it not to, the patient to have heart failure, the same amount of blood that is being pumped in has to be pumped out. If you have any discretions between those, so if you have 500 coming in, you need 500 coming out. If you only have 300 coming out, then that is considered heart failure. So systolic heart failure on the left, when you're looking, it's going to cause less blood flow to be pumped through those ventricles because there's a weakened heart muscle cannot squeeze well enough. So we're going to use medications to help that contractility to be able to squeeze and get that blood pumped through there. On the diastolic heart failure, you're going to have less blood that fills in the ventricles because you have the heart muscle that is stiff. It's going to be enlarged, and so it can't relax as normally as possible for it to be able to fill up all the way. So it's going to have the lack of filling with the blood. Symptoms of signs and symptoms of heart failure. So remember, the left side, you're going to have more of the lung issues. You're going to have the coughing, the shortness of breath, the pulmonary edema, which is the excessive fluid in the lungs. And then you're going to have pleural effusion as well, excessive fluid around the lungs, so around the lung tissue. And then for right-sided heart failure, remember it's going out to the peripheral system. So ascites, fluid that's in the belly. You're going to have edema in the ankles and the legs. They're going to be tired, and they're going to be tired in both of them. The pumping action of the heart grows weaker as the progression of heart failure continues. So disorders commonly associated with heart failure. So these are things that if they have long-term conditions, they will possibly eventually lead to heart failure. So chronic hypertension, coronary artery disease, diabetes, mitral stenosis, and myocardial infarction. Okay, so looking at your vocabulary, the worksheet that I gave you, preload. This is that amount of blood going to the heart and the filling pressure created by that vascular resistance. So this occurs before the chambers of the heart contract. So this is systole, and it is filled to their maximum capacity with blood. And then this is also the degree to which those heart fibers are going to be stretched just prior to that contraction. Because the more they can be stretched, just think the more force that it can be used to pump that blood out. So this is going to, and this will be the strength of your contraction is your contractility. Then the afterload, that is the arterial pressure. This is the pressure in the aorta that must be overcome for the blood to be ejected from the left side of the heart. So remember, where is the left side of the heart pumping the blood out to? It is pumping it out to the periphery. So it's got to be able to have a good contraction to be able to push that blood out. The force of contraction, which is your contractility. This is the ability to increase the strength of the contraction. This is your positive ionotropic effect. Heart rate. This is a faster heart works harder, but not necessarily more efficiently. And a slower heart has a longer time to rest between beats, so this is going to help decrease that workload. The longer it has to rest, the longer it has to recover from, instead of working really hard. And then you have your speed of impulse conduction. So how fast is all of that being conducted? So knowing the blood flow through the heart, the right side of the heart receives the blood from the venous system and sends it to the lungs, where the blood is going to receive that oxygen and it's going to give up the carbon dioxide. Then that blood is going to return to the left side of the heart, where it's going to send it out to the rest of the body through the aorta. Okay, so the first drug that we're going to talk about is cardiac glycosides. The only drug under this section that we're going to talk about is digoxin or lanoxin. So it has both a positive ionotropic and a negative chronotropic effect. So the positive ionotropic effect is going to increase the force of myocardial contraction. And this is going to increase your cardiac output with this. And then your negative chronotropic effect is a decreased heart rate. This is also going to weaken the force of muscular contraction. At therapeutic effects, the digoxin will slow the rate of the SA node, which remember the SA node is the pacemaker of the heart. Depolarization in the rate of the impulses through the conduction system of the heart. So it's going to slow everything down and work more efficiently. So the decreased heart rate will give the ventricles more time to fill with that blood that needs to be pushed out, and it's going to help increase that stroke volume and your cardiac output as well. So therapeutic uses can be used for heart failure, dysrhythmias such as AFib or atrial fibrillation. Okay, complications, dysrhythmias, cardiotoxicity. So this is when it's going to interfere with the electrical conduction in the myocardium. It can lead to bradycardia, so a heart rate less than 60. So with this medication, which we'll talk about again, you need to make sure that you get an apical heart rate before you give this medication, because if it's less than 60, you need to hold it. The conditions that will increase the risk of developing DIG, toxicity, or induce dysrhythmias can be hypokalemia, so your potassium less than 3.5 will increase those DIG levels, and then your cardiovascular disease as well. Your DIG level normal is 0.5 to 2 nanograms per milliliter. So you will need to have, the physician will need to order to get labs drawn to keep a monitor definitely of the potassium and the DIG level. So reports of hypokalemia, nausea, vomiting, general weakness. If they are on a potassium wasting diuretic, making sure that they take a supplement, a potassium supplement to keep that potassium level up, or eating foods high in potassium. If they're on a potassium sparing, make sure that they don't add any extra potassium to their diet. Then GI effects, anorexia is usually the first manifestation of toxicity. Nausea, vomiting, abdominal pain. So if any of these occur, they need to report them as soon as possible. CNS effects, fatigue, weakness, vision changes, blurred vision, yellow-green vision, or white halos around objects is going to be toxic. So they need to report any of those signs and symptoms. Contraindications, pregnancy risk category C. There may be disturbances in ventricular rhythm, so you need to watch for VTAC, VFib, any blocks, AV blocks, third, second degree blocks. So anybody that has these would be contraindicated for this medication. Precautions, hypokalemia, partial AV block, advanced heart failure, or impaired kidney function. Interactions, thiazide diuretics and loop diuretics because they are potassium wasting. ACE inhibitors and ARBs, your angiotensin blockers. Sympathopathic mimetics, medications such as dopamine, which we'll talk about later in the next chapter. Quinidine, verapamil, and antacids. Nursing considerations, like we said before, check the pulse rate before administering. Monitor digoxin levels periodically. So once again, therapeutic levels, this one is 0.5 to 0.8 nanograms per milliliter. Advise against anything over-the-counter medications unless they check with their physician or their provider. Watch for indications of hypokalemia and digoxin as well. The antidote to DIG is going to be digoxin immune fab, which is ovine. This is given IV. Sometimes it'll be referred to as Digivine. because it's going to bind to the dig to get it out of the circulatory system. Onset is rapid, less than a minute. Okay, management of digoxin toxicity is hold the digoxin and potassium-sparing medications, monitor potassium levels. Phenytoin and lidocaine treat digoxin-induced dysrhythmias. Remember, lidocaine is going to be used probably more often than what phenytoin is. We talked about phenytoin used for seizures. Atropine is going to be used to help bring down the heart rate. And digoxin overdose, they're going to use activated charcoal, cholestyramine, or digoxin immune fob, which is ovine, and it's that less than a minute onset. Okay, adrenergic agonist, which is epinephrine, dopamine, dobutamine, and albuterol. The actions are going to be, they're going to stimulate, heart stimulation increases the heart rate, myocardial contraction or contractility, the rate of conduction through the AV node. Activation of receptors in the kidney leads to the release of the renin. Activation of receptors in the arterioles of the heart, lungs, and skeletal muscles lead to vasodilation. Activation of receptors in the kidneys dilates the renal blood vessels. Okay, so epinephrine first is going to be used for AV blocks, shock, heart failure, cardiac arrest. Probably a lot of people you're going to see epinephrine used more for the cardiac arrest and shock. Complications can be vasodilation because you're opening up everything, so you're going to get blood flow very quickly. Sorry. And then cardiac complications can occur with epinephrine as well. Sorry guys, lost where I was. Vasoconstriction, hypertensive crisis due to the activation of the alpha-1 receptors in the heart. It's going to provide continuous cardiac and blood pressure monitoring you need to do while you're giving epinephrine, and watch changes in the vital signs. Cardiac dysrhythmias, it's going to activate the beta-1 receptors in the heart. So it's going to increase that workload of the heart, increase the oxygen demand, leading to possibly angina. So continuous cardiac monitoring, monitor for dysrhythmias, change in heart rate and chest pain. And then if you have any dysrhythmias or changed in the heart rate or increases in the heart rate and chest pain, make sure you notify the physician. Pregnancy risk category C is contraindicated for epinephrine. Precautions: hyperthyroidism, angina, cardiac dysrhythmias, or hypertension. Interactions are going to be your MAOIs and TCAs and general anesthetics. Therapeutic uses: for dopamine, you can use for shock, heart failure, and acute kidney injury. A lot of times we're going to use it more for the kidneys function because it'll help increase that urine output. Complications for dopamine is cardiac, the beta-1 once again in the heart can cause dysrhythmias. It also can increase the workload of the heart, increase oxygen demand that could lead to angina. So same thing, cardiac monitoring, monitor for dysrhythmias, change in heart rate and chest pain, and notify the physician if any of those occur. Once again, dopamine is very necrosis to the tissues, so it is a drug that is better given through a central line, a PICC line, because it's centrally located where it needs to be. If it's in a peripheral site, you got to make sure that you have blood return. You need to check blood return also in a central line if the patient has one. As soon as you lose blood return, you need to start finding another site to move that to, because it may not be infiltrated, but you don't want to take that chance of that occurring. And then there is antidote to give to that. It's phenytolamine. It's an alpha blocker. You're going to inject it into the actual IV site itself, and then around that site to help decrease it from necrosing the tissues. I've seen it happen, and it's not pretty. It kind of looks like a flesh eating is what's going on. Contraindications, pregnancy risk category C, tachydysrhythmias and ventricular fibrillation, hyperthyroidism, angina, history of MI, hypertension, or diabetes mellitus. Interactions, MAOIs, TCAs, and general anesthetics. Dobutamine is used for heart failure. A complication can be tachycardia. So you need to have them on vital signs monitoring and cardiac monitoring as well. Contraindications are pregnancy risk category B, hyperthyroidism, angina, a history of MI, hypertension, and diabetes mellitus. Interactions, MAOIs, TCAs, general anesthetics. For the whole classification, IV continuous infusion and IV pump, so you cannot run these by gravity. It has to be on a pump. Titrate according to the blood pressure response. Dopamine, you're going to stop the infusion at the first site of irritation, which I talked about. Monitor chest pain and EKGs, monitor urine output, and then monitor the perfusion of the extremity. So cap refill, color, warmth, coolness is what you're going to be checking for.